Hi, Professor Palmieri here, giving you a basic neuro assessment. Today we're going to go through, let me get my screen shared with you so you can see where we are. Basic neuro assessment. We're going to start with just some basic pertinent history that you might see in patients with neurologic deficits. Your primary assessment technique is inspection paired with questioning. So I'm going to be looking and talking to the patient, but I may also ask them deliberate questions to try to get to the get honest feedback about their neuro situation. Some of it's nice to have just see how they respond to you, but some of it will be deliberate questioning. Some pertinent history that you might see in patients with neurologic problems might be a CVA. This is not an all-inclusive list, by the way, which stands for cerebrovascular accident, which is another name for a stroke. They may have Bell's palsy. Now, Bell's palsy can look like a stroke, but it's limited to the face. So there's some facial nerves that have gotten paralyzed, perhaps because of a little viral infection or some other trigger that has paralyzed those nerves. It's usually temporary and it can be resolved, usually limited to the face. So it'll be up in this area and you'll see when they smile, one side will smile, but the other side doesn't. So that's Bell's palsy. Also, traumatic brain injuries, spinal cord injuries, the various types of dementia. There's Alzheimer's and there's Lewy body and frontal temporal lobe dementia. There's all kinds of different dementias. Drug, alcohol use or intoxication. Something called tardive dyskinesia, which is a movement disorder. It typically is associated with some mental health meds. Some of them can cause involuntary movements. So if you see that, that's called tardive dyskinesia. And also seizure disorders would be something you might see in a patient's history. Okay. Some common symptoms that the patient might report to you might be some type of paralysis, maybe one leg or one arm, or this hand isn't working quite right. I can't get a grip on it. Or it feels tingly, numbness and tingling, or a pins and needles sensation, headaches. And there's a whole myriad of different varieties of headache also. So your questioning when a patient has a headache is going to help the healthcare provider figure out what type of headache the patient's having. Also, seizures may be new onset seizures, or it could be that they've had seizures, but something has changed about those seizures. Maybe they're getting worse or they're happening more often, or there's some type of different behavior or movement that's being noticed during the seizure. Maybe they feel different after the seizure. That's something that's different. Loss of consciousness, gait problems or coordination problems, dysphasia, which is difficulty with words and speaking, or dysphagia, which is difficulty swallowing. So all of those things are associated with neurologic deficits. When you check PEARL or PERLA, that also is part of your neuro assessment. I'm going to review that with you also. I'll do that at the end so that I kind of get back to assessment all at the same time, so I'm not flipping back and forth. Some things to notice as you're talking to the patient that are neuro noticing things to be aware of. Are they able to understand you? Do they seem like they're understanding what you're saying? Are they answering back appropriately? Is the conversation appropriate for what's happening? Does it seem like the patient can hear you? Not being able to hear, and the patient, sometimes they don't want to admit that they can't hear, so they might try to punt and try to think, well, I think they said this, so they may answer something and it may not be the right thing. It might be because they didn't hear you appropriately. So make sure that when you think the patient might be confused, that it's not just a hearing issue. And I'm going to tell you how you can question that. Look at the I can't speak, symmetry of the face and body movements as they're talking to you. Does their face look the same on both sides, right and left? Or do you notice any kind of repetitive movements? Are there any kind of tick-like movements or habits that they might have? Does one side of the face kind of have a drag to it? Look for any abnormal movements. And then as part of the focused assessment later, we're going to learn a little bit more about sharp and dull and strength testing and sensation testing. But today we're just keeping it real simple with just basic neuro assessment. Orientation questions. You don't always have to ask all of the orientation questions. A lot of your patients are alert and oriented ×4, and you can tell by the way they answer the questions that you ask them and the way they interact with you. But if you're ever not sure, like maybe you think, I can't tell if this guy is not hearing me or if he's really disoriented. So then you have to ask the questions. And it may feel weird to you to ask the questions because they are kind of odd questions to ask the average person. So you can preface your questions by saying, I have to ask you a few questions that might seem a little odd to you, but I just have to ask them. And the patient will say, okay, sure. What time is it? So I don't mean what clock time it is. I mean, is it morning, afternoon, evening, or nighttime? So most patients don't know what time it is without seeing a clock. And they can look at a clock and give you the right answer, and that's still not going to tell you whether they're really with the program or not. So that's why I ask things like, what meal did we just have? Yeah, that's good enough. What meal did we just have? Or what are we about to do? If you're getting ready to put the patient to bed, what are we about to do? Oh, I'm about to go to bed. So that might be something you can ask. Where are we? So they may not know the name of the place they are. They may not be able to distinguish an ER room from a hospital room, but if they can say, I'm at the hospital or I'm in the ambulance, that will tell you enough to know that they know where they're at. Most patients can tell you their name and date of birth. And when they do that, you don't have to ask it again. You already asked them that to give them meds or to introduce yourself to them or to initiate care with them. So that right there, you can already tell that the patient is oriented to person. And then ask them about the situation if you haven't already asked them. So if you're not sure what's going on right now, or if they know what's going on right now, just ask them, what are we doing? What brought you here? A lot of times that will tell you, well, I had some chest pain last night. And that if they tell you the whole story of how they came in, you know they're oriented to situation. Now I'm going to stop sharing my screen because I'm going to go through Perla with you again. Just to make sure. I think I did in a previous video, but I want to make sure that we have it covered so you know what to do. With Perla, it stands for pupils equal, round, reactive to light, and accommodation. I don't always check accommodation on every patient, okay? And it's okay if you leave it off, okay? That's not a big deal. If you don't do it, don't chart it, okay? So if you did Pearl, but not you would just document PERRL and then the millimeters of your patient's pupils, okay? That's better than not doing it and documenting that you did. I'd rather you just be honest and say, I didn't check accommodation, and it's not a big deal, okay? So how you do it on a real person and how you do it on Susie or one of our high fidelity mannequins is a little bit different. On the mannequin, you got to shine the light right in their eyes, right square in it, close, and you can hear it. Can hear it. I don't know if you could hear it if the microphone picked that up, but you can hear it make a little sound, and I could see the pupil get really small. On a real person, you're going to come out from the side and do it. Okay, just don't shine the light directly in their eyes. Leave that for the ophthalmologist. That's uncomfortable. And then you see like all those little blood vessels in your when you look away, you can still see them on the wall. Let's try not to do that to our patient unless we are really having a hard time getting the pupil to react. Okay, but generally just come in from the outside here, and if you shine it out here, they should both constrict at the same time. Do each side to make sure that they both do. Once in a while, you'll get one pupil that's a little bit bigger than the other. Don't get alarmed by that. Sometimes it might be because you're sitting next to a window and the light's coming in this side, so this pupil might be a little smaller than this side. Nothing to get worked up about. And a lot of times, if you find a new, what you think might be a new finding, just document it, mention it to the healthcare provider, and they can sort out if it's something new. You could be the person finding a new finding in a patient. But a lot of times there are things that have been present for years and the patient may or may not be aware of them. But that is your basic neuro assessment, pretty cut and dry and easy. I will see you in August.